Discuss about diagnosis, signs and symptoms. So first of all, what is important is early identification of maternal danger signs and warning system is critical. Okay, early identification. So what are the, if we talk about what are the severe complications of HDP, then they are eclampsia, HELP syndrome and other system involvement, placental abruption, preterm birth or IUD. So why maternal alerts are important in HDP? First of all, we can go for an early action, okay, which can prevent eclampsia, HELP and maternal death. And secondly, it helps in reduction of maternal and perinatal morbidity and mortality. So what are the signs which you should monitor? First of all, it is high blood pressure, that is more than or equal to 140 mmHg. Brisk tendon reflexes, altered consciousness, sudden onset of massive edema, significant protein in urine, reduced urine output, reduced fetal movements and vaginal bleeding and uterine tenderness. Okay, and what are the biochemical and biophysical alerts? So this is very important, biochemical and biophysical alerts. It is actually SpO2 less than 95%. So it is a question which you should know. Less than 95%, LDH is more than equal to 600, serum creatinine more than equal to 1 mg per dl, AST/ALT more than 2 times of the upper limit, and platelet is less than 1,50,000, serum uric acid is more than 5 mg per dl. So I think all these are parameters which you already know. Newer one is serum uric acid more than 5 mg per dl and SpO2 less than 95. Okay, now talking about proteinuria. Proteinuria is actually defined as more than equal to 30 mg per millimole PCR, that is protein creatinine ratio. And if we talk about albumin creatinine ratio, then it is more than equal to 8 mg per millimole. And in a 24-hour urine collection, it should be more than equal to 0.3 gram per dl. And urine dipstick is more than 1+. So this is very important. More than equal to 1+ by urine dipstick. So you should know that this PCR report, it usually comes in 2 to 4 hours. And this 24-hour urine collection, though they have written here that value and all everything, but it has no advantage. Okay, now yes, so when blood pressure reading of pregnant woman is more than equal to 140 by 90 mmHg, or she is a known case of chronic hypertension, visits first time to the antenatal, following investigations are advisable. So what are the investigations that you should do? First, if we talk about the baseline investigation, then of course, as I told you, it is PCR, then complete blood count, liver enzymes, ALT, AST, LDH and serum creatinine. I have given you the values for it also. Now these are the additional laboratory investigations. So see, if in CBC your platelet count was less than 1,50,000, at that time you need to go for a coagulation profile. Okay, and in severe cases serum electrolytes need to be done. Talking about ultrasonography, fetal surveillance and placental morphology, of course fetal biometry, amniotic fluid index and fetal Doppler should be performed. Okay, you should also know placental location morphology and any evidence of placental bed hemorrhage. Abnormal adherence or presence of sinusoids, this is also important. Abnormal adherence and presence of sinusoids should be documented. Okay, you should apart from fetal surveillance and placental morphology, you should also go for maternal abdominal ultrasound, and in this you need to assess the maternal organs like liver. In liver you will see for subcapsular hematoma and hepatomegaly. In kidney you will see for renal causes of hypertension, other changes in renal parenchyma, and you will check for ascites and pleural effusion because these are worsening signs of preeclampsia. Okay, so fundoscopy, it actually differentiates between chronic and new onset disease, and what will you see? You will diagnose papilloedema and hemorrhage omnious prognosis, because these are omnious prognosis. So what are the additional imaging? One is the 2D maternal echo. in these this 2D echo has to be done in all cases of preeclampsia. It actually detects left ventricular dysfunction, okay, and important where mother is at high risk of CV symptoms, cardiovascular system. Now MRI for brain, actually neuroimaging is not recommended universally in all cases of preeclampsia. It is only necessary if there is a diagnostic dilemma of eclampsia, cerebral venous thrombosis, press, or so now talking about the biomarkers. The angiogenic markers like platelet growth factor or SFLT1 platelet growth factor ratio, this could be performed. Now you have to remember the values. Normal platelet growth factor is more than 5th centile for gestational age or 100 picogram per milliliter on spot test, okay, or normal SFLT1 platelet growth factor ratio is less than 38, okay. If these values are there, then it suggests that there is no uteroplacental dysfunction, right? And if we talk about the spot platelet growth factor, then it should be 12 picogram per milliliter, or SFLT1 platelet growth factor ratio, it should be more than 85 to indicate the high risk of development of complications. So these are some values which you should remember, okay. Now talking about the follow-up investigations. Follow-up investigations upon admission to delivery room, women with preeclampsia should have a platelet count irrespective of when this was last performed and any other required investigation. So one thing that you have to remember is having a platelet count repeated irrespective of when it was last performed. Now in chronic hypertension, we are talking about the follow-up investigations. Chronic hypertension, all women with chronic hypertension should have a baseline laboratory investigation performed at first diagnosis in pregnancy. This provides a reference should suspicion arise later in pregnancy of superimposed preeclampsia. Okay, why it is important to do a baseline scan, baseline investigation? Because it will provide a reference if there is a suspicion of superimposed preeclampsia later in pregnancy. The frequency of follow-up investigation should be guided by blood pressure and other individual risk of adverse outcomes. Now talking about gestational hypertension, all women with hypertension should undergo testing for preeclampsia as mentioned, okay. Normal values confirm the diagnosis of gestational hypertension if it is not preeclampsia. Proteinuria testing should be performed at each subsequent antenatal visit, okay. If she has been labeled with gestational hypertension in each subsequent antenatal visit, you need to do a proteinuria testing. Now patient may be admitted in daycare. Remember, if there is an admission, it should be in daycare for further evaluation and prognostication. Follow-up should occur at least once weekly, okay, at least once weekly. This timeline is very important, okay. Antenatal fetal surveillance in HDP. Now we are talking about antenatal fetal surveillance. So hypertensive disorder of pregnancy, it of course increases the risk of uteroplacental insufficiency, fetal growth restriction, oligohydramnios, preterm birth and stillbirth, okay. Hence fetal surveillance is essential to detect early fetal compromise and balance the competing risk of prematurity versus in utero hypoxia. A frequency of fetal surveillance, okay. If we talk about the baseline, the anatomy scan with uterine artery Doppler should of course be done. Then there is a risk stratification needs to be done, and if previous risk factors like chronic hypertension, prior FGR or abnormal uterine artery Dopplers are present, serial growth scans need to be done from 28 weeks onwards, okay, if there is a previous risk factor. So talking about chronic hypertension or patients with previous history of severe preeclampsia, placental abruption or IUFT, you need to do a growth scan with Doppler every 4 weeks and it should be starting from 28 weeks. Okay, talking about gestational hypertension or hypertension with severe feature without severe features, that means gestational hypertension and simple preeclampsia. There you have to do growth scan with Dopplers at the time of diagnosis, and if it is normal then 4 weekly. Frequency of subsequent scans will depend on ultrasound findings and severity of hypertension. Now comes hypertension with severe features or preeclampsia with severe features. Okay, here you need inpatient monitoring on admission, or if clinically indicated, you need to do a CTG, okay, on diagnosis or admission. And CTG, that is NST, we call it NST, and biophysical profile can be done. CTG can be either normal CTG or computerized CTG, okay, for routine antenatal testing modality. Now if the pregnancy continues, you have to do 2 weekly growth scans with weekly or alternate Dopplers. So once in every 2 weeks you have to go for growth scans, okay, and either weekly or on alternate days you have to go for Doppler. Okay, now frequency of everything will depend on Doppler finding and severity of maternal condition. Okay, so talking about the frequency of fetal surveillance, this was according to the degree of hypertension. The fetal surveillance are based on degree of hypertension that the female is having. Now is what is the fetal status, to that will decide the frequency of fetal surveillance. So first is, if there is no FGR or it is a very mild disease, you need to do growth scans every 3 to 4 weeks and CTG only as required. Now if it is FGR with abnormal uterine artery Doppler, like example increased PI, then you have to do growth scans every 2 weeks. Here it was once in every 3 to 4 weeks, here it is 2 weekly, okay. And Doppler you have to repeat it either weekly or once in 2 weeks, okay. And NST has to be done 2 to 3 times in a week depending on severity. Then third is, if there is FGR and there is absent end diastolic flow or reversed end diastolic flow in the umbilical artery, or abnormal ductus venosus Doppler before 32 weeks, or abnormal MCA with CPR less than 5th centile after 32 weeks. You should remember that before 32 weeks we can decide based on ductus venosus Dopplers, and after 32 weeks only there is role of MCA or CPR, okay, cerebroplacental ratio. Then patient needs to be monitored closely with possible inpatient management and daily CTG.